Hello everyone. Artificial intelligence is rapidly evolving in medical imaging, particularly for prostate MRI. Today, we'll explore how we can leverage these powerful tools effectively in our clinical practice. As you can see, this is an area of active research and development, reflected in position papers and ongoing work like those highlighted here from European Radiology, focusing on development, validation, and human-AI interaction. Before we begin, here are my relevant disclosures for 2025. Notably, I have research support agreements and serve on scientific advisory boards for Siemens Healthineers and Lucida Medical, companies active in this space. Our objectives for today are threefold. First, we'll consider the essential criteria you should use when selecting deep learning computer-aided detection or DLA-CAD software for prostate cancer diagnosis. Second, we'll review and compare some of the commercially available DLA-CAD tools, looking at their capabilities. And finally, I'll offer practical advice on implementing these AI tools into your clinical workflows. Let's start by grounding ourselves in the current clinical context. The EAU 2024 guidelines firmly place MRI at the heart of the early prostate cancer detection pathway for men with elevated risk. As shown here, MRI serves two crucial functions. Firstly, for risk stratification to guide biopsy decisions, deciding who needs a biopsy, and secondly, for planning and targeting that biopsy if it proceeds. AI tools aim to enhance both of these aspects. The benefits of this MRI-led pathway, established through multiple large trials summarized in the Vision meta-analysis, are significant. Compared to systematic biopsy alone, it reduces the number of men needing biopsies, decreases the diagnosis of indolent, low-risk disease, improves the detection of clinically significant Gleason grade group 2 or higher cancers, and leads to more accurate targeted biopsy cores. When evaluating any diagnostic tool, including AI, we think about its rule-out ability, its negative predictive value, and its rule-in ability, its positive predictive value. These concepts are central to understanding how AI can help. So, how well do we perform as radiologists using the standard tool, PI-RADS version 2.1? This large meta-analysis by Earther and colleagues, covering 70 studies and over 13,000 patients, looked at patient-level accuracy using a PI-RADS 3 to 5 cutoff for detecting GG2+ disease. The results show very good sensitivity, averaging over 90%. However, the specificity is moderate and, importantly, highly variable, often below 60%. This variability and lower specificity represent a key challenge in current practice. We find most significant cancers, but we also trigger many biopsies for benign findings or low-grade cancers, especially with PI-RADS 3 lesions. This is an area where AI potentially offers significant value, and AI is showing promise. The PI-CAD Challenge was a landmark international competition and subsequent validation study. It tested a combination of the top 5 performing AI algorithms against 62 radiologists from 45 centers reading 400 cases, using biopsy or long-term follow-up as the reference standard. Crucially, this study evaluated the AI in a standalone performance setting. The results, published in Lancet Oncology, showed that, on average, the AI system demonstrated better performance than the pool of radiologists using PI-RADS v. Specifically, the AI achieved similar sensitivity but with 50% fewer false positives, detected 20% fewer insignificant GG1 cancers, and had 50% fewer false negatives at the PI-RADS 3 to 5 threshold. You can also see the highly variable performance of the individual radiologists confirmed on the ROC plot. This highlights the potential of AI, though remember this was standalone, not as an assistant. This brings us to the core question: is DLA-CAD software ready for routine clinical use? We see increasingly promising results comparing AI to radiologists and pathology. Performance, especially for detecting significant GG2+ cancer, can be as good as a trained radiologist. However, studies also show that AI-assisted reading doesn't universally help everyone, particularly experienced readers. Workflow optimization is crucial for realizing benefits. Furthermore, there are still relatively few prospective studies evaluating these tools in real-world clinical settings. As you can see from the AI for Radiology Grand Challenge website, numerous CE-marked and FDA-cleared tools are now available, but importantly, none of these have been comprehensively validated in prospective clinical studies in terms of improving diagnostic accuracy or workflow efficiency. So, conceptually, how do we integrate these tools? We have the radiologist, often with variable experience levels, and the DLA-CAD software. The goal is to use the software as a tool with proven clinical utility, functioning as a diagnostic assistant to improve the radiologist's performance and also aiding in biopsy management and planning. Commercially available DLA-CAD software typically offers functions that fall into two main categories. First, the assistant role, helping radiologists perform their diagnostic work more efficiently, accurately, and consistently. This might involve highlighting suspicious areas, providing measurements, or suggesting scores. Second, biopsy management, providing outputs like lesion segmentations or coordinates that contribute directly to urological biopsy decisions and planning, often integrating with fusion biopsy systems. So, if we're considering adopting DLA-CAD, what are the practical next steps? Beyond the promising performance data, we need to delve into further considerations, as outlined by Sunacrot and colleagues. These include establishing clear criteria for selecting software, identifying the critical clinical tools the software must provide, understanding the radiologist, AI interface, figuring out how to integrate it into existing workflows, and developing standard operating procedures or SOPs. Let's start with selection criteria. This table outlines key aspects across different categories. Necessary criteria include external validation comparing performance to radiologists or pathology, and regulatory clearance for clinical use. Recommended criteria include performance similar to standard of care radiologists, training on multi-site, multi-vendor data. For robustness, easy integration into your local workflow without causing delays, and generalizability across different MRI vendors and field strengths. Aspirational goals include prospective trial validation, deployment on multiple platforms, accommodating both biparametric and multiparametric MRI, and incorporating clinical data like PSA or age. Next, let's focus on the critical clinical tools the software should offer. What functionalities do we need? Necessary, the software must detect, localize, and classify suspicious lesions, providing an accompanying probability or level of suspicion score for clinically significant cancer. Recommended, it should allow radiologist interaction, the ability to accept, reject, or modify AI findings. It must also provide the prostate volume for p-AD calculation, which is crucial for risk assessment. Aspirational but highly valuable features include heat maps for lower suspicion areas, auto-generation of PI-RADS compliant reports, user-adjustable regions of interest for analysis, explainable AI. Features lesion expansion tools for biopsy targeting or radiotherapy planning, DICOM RT object export for fusion biopsy and RT planning, and user-adjustable thresholds for false positives based on clinical context. Here's an example of what a typical AI output might look like on a workstation. You can see the software has segmented the whole gland and zones. It has detected a suspicious lesion, provided quantitative data like ADC values and volume, and assigned a PI-RADS category or likelihood score. Importantly, note the arrow pointing towards regional biopsy core's focal boost RT ablation zone. This highlights how the AI-generated lesion delineation can directly inform biopsy targeting or planning for focal therapies. The output is often summarized in a report. Here are examples from Lucida Medical and Quibim. They typically list detected lesions, their location, size, volume, and an AI-derived risk score or suggested PI-RADS category, often presented alongside key patient information like PSA density. These reports aim to standardize the communication of AI findings. Now let's consider the crucial aspect of how the radiologist interacts with the AI, the interface. AI tools interact with clinicians in different ways, often categorized using FDA terminology as described by McNamara and others. CADE is purely for detection. It marks suspicious regions or provides heat maps. CADEX explains the nature of a pre-identified lesion, perhaps providing a score or probability of malignancy. CADEX does both, detects and characterizes lesions. CAT acts as a triage tool, flagging potentially positive cases for priority review. CADA is autonomous, providing an interpretation without clinician input. Non-CAD tools perform other tasks like segmentation or reporting assistance. These different types manifest differently in the workflow, from simple marks on images to detailed lesion analysis to work list prioritization, potentially feeding into MDT discussions. Looking at some examples, Lucida's tool functions as CADE-X, detecting, characterizing, and potentially triaging, prioritizing lesions and patients on a work list, as shown here. Siemens AI RAD Companion is primarily CADE-X, detecting and characterizing lesions for radiologist review and editing, with biopsy export capabilities. DeepHeath Quantib, as we'll see, functions mainly as CADE, providing heat maps to guide the user. Deployment also varies. Some AI tools integrate into third-party platforms, meaning they can run within your existing PACS or vendor-neutral archives like Sectra, Blackford, or national platforms like the NHS AI Deployment Platform. Others run on proprietary platforms, often the MRI vendor's own advanced visualization software or standalone workstations provided by the AI vendor. Some offer both options. Here's an example of a CADE system, Quantib Deep Health. It provides a likelihood of cancer heat map overlaid on the images. Notice there are no automatically delineated lesions or suspicion scores assigned to specific findings. The radiologist or urologist uses the heat map as a guide to manually segment suspicious areas, classify them, and plan biopsies. The classification and decision-making remain entirely with the user. In contrast, here's an example of a CADE-X system, the Siemens AI RAD Companion. This tool automatically detects suspicious lesions, delineates their boundaries, calculates volumes and quantitative parameters like median ADC, provides a level of suspicion score, and suggests a PI-RADS category. It allows the radiologist to review, edit, accept, or reject these findings and can export lesion information for biopsy planning. This offers a higher degree of automation as a starting point for the radiologist. Understanding the different AI types and interfaces leads us to the next critical point. How do we effectively integrate these into our clinical workflows? The most straightforward workflow is decision support. Here, the AI runs concurrently or just before the radiologist reads the scan. The AI provides its predictions, scores, or highlighted regions. The radiologist considers this AI information alongside their own assessment to finalize the clinical report and influence biopsy decisions. Clinically, this is often most useful for less experienced readers. A key consideration is ensuring AI outputs are clear, understandable, and actionable. Crucially, radiologists must understand the AI's limitations and use the information appropriately to avoid automation bias, the tendency to over-rely on the AI, especially when it confirms their initial impression, or to dismiss discordant findings too readily. Let's look at a case illustrating potential pitfalls. This 74-year-old man had stable low PSA but concerning symptoms and family history. The radiologist interpreted the scan as PIRAD5 and the AI concurred, highlighting a large lesion in the right transition zone with a high suspicion score. However, despite the PIRADS5 read and the AI flag, extensive biopsy sampling of the targeted area, including 27 cores in total with 5 targeted to the right TZ, came back negative for malignancy. The pathology showed only benign prostatic tissue with very mild chronic inflammation. This serves as a reminder that even concordant high suspicion reads from both human and AI can be false positives, potentially due to factors like inflammation mimicking cancer on imaging. Another approach is using AI as an additional reader or safety net. The radiologist performs their standard read. Separately, the AI analyzes the images, typically operating at a high sensitivity setting to minimize missed cancers. The AI flags any suspicious findings, particularly those potentially overlooked by the radiologist. The clinical consideration here is that the AI's operating point must prioritize sensitivity. However, this inevitably leads to more false positives. The MDT team, especially urologists receiving these reports, must be trained to critically evaluate AI flags and avoid urologist automation bias, where an AI flag might unduly push towards biopsy without careful consideration of the full clinical and imaging picture. Here's an example of a potential false positive from an AI operating in a high sensitivity mode. This DLA-CAD heat map strongly highlights areas which might be flagged in an additional reader workflow, requiring careful review by the radiologist or urologist to determine clinical significance. The potential trade-offs of the additional reader approach were shown in this recent prospective study by Genzel and others using a CAD system. They found that AI detected GG2+ cancers in 4% of men that might have been missed and identified additional GG2+ lesions in 8% of men. However, this came at a cost. The number of target lesions identified increased by 54% compared to the radiologists alone, and the false positive rate per case effectively doubled. Looking at the performance metrics, while per-patient sensitivity increased slightly with AI, the per-lesion PPV dropped significantly from 46% to 30%, and specificity decreased. This highlights the crucial sensitivity-specificity trade-off when using AI as a high-sensitivity safety net. Just to re-emphasize the key findings from the Genzel study, a significant increase in the number of target lesions identified for potential biopsy, and a doubling of the false positive rate per case when using this CAD tool in an assistive manner compared to radiologists' findings alone. A third workflow is AI-assisted targeted review. Here, a high-sensitivity AI acts as a pre-reader, highlighting all potentially suspicious lesions. The radiologist primarily focuses their review on these AI-highlighted areas, making biopsy decisions for each. The radiologist also verifies the AI's negative cases, acting as a safety net to catch any AI misses. The goal is enhanced cancer detection via high AI sensitivity, coupled with improved workload efficiency by focusing the radiologist's attention. However, the risk of automation bias remains. Radiologists must critically evaluate the AI-highlighted lesions and not just accept them, and must remain vigilant when verifying negative cases. So, we've discussed several potential AI-integrated workflows for a single reader setting, summarized here and detailed further in our upcoming uroradiology paper. These range from simple decision support, using AI as an additional reader or safety net, the focused assisted target review, using AI for triage to direct cases, using high-confidence filtering to fast-track clear cases, and potentially even standalone AI interpretation in the future. This diagram visually summarizes these workflows, showing the flow from MRI acquisition through potential AI analysis, radiologist interpretation, and finally to MDT urology decisions. The arrows illustrate the different points of interaction and decision-making in each model, from standard care with no AI through the various assisted reading modes to a fully standalone AI scenario. Regardless of the chosen workflow, successful and safe implementation requires standardization. This brings us to the final consideration, standard operating procedures or SOPs. Developing a local SOP is crucial for consistent and effective use of AI assistance. This should include steps like always accounting for clinical history, checking image quality, as poor SNR or artifacts can affect AI performance, verifying the AI's prostate gland segmentation, especially at the base and apex where lesions can be missed if outside the contour, carefully reviewing the ROIs identified by the AI, are they likely true detections, reviewing heat maps even without defined ROIs to look for subtle signs or understand dismissed false positives, being aware of common false detections, actively reviewing known AI blind spots, classifying lesions using all available MRI sequences, incorporating the AI score but ultimately assigning your own PIRADS Likert score, potentially adjusting your tolerance for accepting AI findings based on clinical priority patient factors or PSAD, ensuring correct export of DICOM RT objects if using for fusion biopsy or RT planning, and using the AI output to help auto-generate standardized reports. Remember, SOP stands for Standard Operating Procedure. Consistency is key. So, before investing in a DLA-CAD system, here are some key questions to ask the vendor and yourselves. What is the primary work task you need it for? Radiological assistance, biopsy management, or both? What validated performance data does the software offer at both the patient and lesion level, specifically compared to expert radiologists? Will it genuinely help with the challenging PI-RADS3 lesions? Does it offer expert-level performance there? What is the user interface like? And what workflows does the vendor recommend and support? Does it fit your workflow? Does it work with your specific MRI images? Or does it require calibration? What is the degree of automation? What explainability features are offered? Can you understand why the AI made a finding? And finally, what are the outputs? Does it generate PI-RADS reports? Does it provide accurate volumes, exportable ROIs suitable for RT and fusion biopsy systems? To conclude, let's summarize the key learning points regarding AI radiologist interaction workflows. First, human-AI collaboration appears key to unlocking the full potential of MRI. AI can improve detection, reduce inter-reader variability, and potentially reduce unnecessary biopsies. Second, AI can contribute to improved workflow efficiency, particularly through triage or filtering scenarios, freeing up radiologist time for complex cases. Third, we urgently need robust benchmarking metrics for both rule-in and rule-out performance, specifically tailored to evaluate these different AI radiology workflows, not just standalone AI. Finally, more prospective studies are essential to evaluate the real-world radiologic interactions with diverse AI systems, quantify any time or efficiency gains, and assess the generalizability of findings across different patient cohorts and clinical settings. Thank you for your attention. I hope this overview provides a practical framework for thinking about and effectively implementing prostate AI software in your practice.